stop it from repeating, but you'll get a sense. These are two famous people that I think you will recognize, but if you don't, ask the person next to you, particularly for the second one. It's probably age-related. Maybe the first one, too. It shows it 3 times, just for emphasis, I think. Pause it and go to the next one. Okay. All right, here is the second one. Okay, so there you have 2 falls, Fidel Castro and Carmen Electra and her friend who was trying to help her. So, you know, there are two falls, and what is leading to these falls? Anybody have an idea? Ideas? Well, what was going on there? Rosalind. Yes. So he went down a step, and he wasn't able to control himself after that, which could mean he has a balance problem or some strength problem, but he obviously did not see the step. What happened in the second one with Carmen Electra and her friend? Slippery floors and a tire. And a tire. Slippery floors and a tire. So there we have an environmental problem, 2 environmental problems, an entire problem, and maybe a balance problem or something like that, which are, as we'll see, risk factors for falls. So why are falls a problem? For a lot of reasons. One is that 1/3 of older people fall each year, so it is a very prevalent problem. Over 10% of these people are seriously injured, which means they have a hip fracture or a head injury. About 20% of people who fall are hospitalized for the fall. So it's an injurious problem. It is a costly problem. So fatal falls, which can be a result of head injuries or even hip fractures, cost the country about $179 million. Non-fatal falls over $19 billion, and in the year 2020, about almost $55 billion. So we're talking about something very costly. Falls are also the major non-fatal unintentional injury among older people, but most people think about unintentional injuries in terms of motor vehicle accidents because those are the ones that get the press. But we have a whole list of famous fallers who have fallen, who are identified in their obituaries as that having happened to them. So in addition to the risk factors that we identified, there are others that are significant and we'll talk about. One is balance deficits. Another is visual deficits. Chronic diseases, osteoporosis. We will skip cognitive impairment, although that is a high risk factor for falls because people have poor judgment and depth perception. Other ones are multiple medications. So some of the things that Margie might or her colleagues might suggest to deal with depression can also contribute to falls. So that's a serious problem of those kind of medications and multiple medications. And hazards in the home. And improper footwear. I'm sure that Carmen Electra was wearing these very spiked heels. We just couldn't see them in that particular video. So there are multiple factors that can lead to falls. And that's why it's considered a condition and not a disease. Treating the underlying diseases can help, but the conditions themselves can work together to increase your risk of falls. So how do we reduce falls? The The good thing is, opposed to some of the diseases, there are ways to reduce falls significantly. And Rand has done a meta-analysis. My colleague Larry Rubenstein, who's associated with our center that I will talk about, has done a series of meta-analysis, and basically it's 3 factors that are the most important to be able to reduce falls. Medical risk assessment and follow-up, and that includes medications. Balance and strength training, so it's not just any kind of exercise. And environmental risk assessment and modification. And just to show you a risky behavior over here is this lady on the step stool who I went to her house because her son requested it, and I asked her to show me how she did things, and she showed us how she got on the step ladder to reach things that were high, and her son had his eyes covered while she was doing this. She hadn't fallen before, but that's a very risky behavior. The simple solution is to get a better step stool or to move things down to a level where you can reach them. So I'm going to talk to you about the Fall Prevention Center of Excellence because it is an organization that I'm one of the co-directors of to try to create an agenda to reduce falls. And to show you the multifactorial nature of it, it involves the USC Andrews Center, and our expertise is on the environment. It involves Cal State Fullerton. Their expertise is on kinesiology and physical activity related to falls. The UCLA and the VA is geriatric medicine related to falls. And the California Department of Public Health, because it really is a public health issue. So we have a strategy that we've been working on for 5 years, and the strategy is really a public health approach to dealing with falls. So it's not really like one hip fracture at a time. It is an attempt to change the system in a way that will work together to reduce falls. So one of it is improving data collection, educating professionals. Third is promoting consumer education and empowerment, developing and disseminating information about evidence-based programs, facilitating coalitions and networks, and influencing policy and legislation. So this is a very broad agenda of strategies to help reduce falls, particularly aimed at California. Most of our efforts are funded by the Archstone Foundation with support from other ones as well. So we have been working hard to fill in the gaps about falls because the data is so poor that the only really good data about falls that you can collect from older people is to have them keep a calendar of when they fall. Because most of the data sets that you've heard about that deal with diseases, they'll ask about how many times did you fall in the last 2 years? Well, people's memories aren't that good and they underestimate falls. And so we've been working hard to create better cost data and incidence data so decision makers and policy makers can address the problem. A second strategy is to try to educate professionals. And let me give you an example of physicians. So physicians routinely under-assess falls. They don't ask people about falls. They do very quick assessments. Geriatricians do a better job of it. But we know that physicians underestimate falls by doing studies. And so we have been training physicians through a variety of different mechanisms to do the following. To ask every older person over 65, have they fallen? If they've fallen, to do an assessment of balance and gait and to watch how they walk. And then she just told me I'm doing a good job, keep going. And for persons who are at high risk of falls, to do a more thorough assessment. And we're doing this kind of assessments with other groups too. So those are the groups we're trying to influence. A second is to promote consumer empowerment and education, because older people do not go to their healthcare providers often enough to say, I've fallen. They are somewhat embarrassed. They think it's something that shouldn't have happened and they were stupid, like maybe Fidel Castro's fall. or they are denying that they're at high risk of falls, and they don't think there's nothing can be done about it. So we have created a couple of programs to empower people. They include staying independent, a self-risk assessment, and the messaging is important. I'm sure you might remember the ad on TV where a person's falling down the stairs, and basically the ad goes, I've fallen down and I can't get up. That doesn't work as a motivator to change people's behavior except in the short run. So we're trying to empower people to go talk to their doctors. We produced educational material so people can do their own home exercises. And we've created a sheet on how to talk to your doctor about falls. So you can see we're working all ends of the spectrum to try to change the mechanism related to fall assessment and risk reduction. Evidence-based programs have become sort of the norm in terms of what the government wants to see in places like senior centers. But most of the fall programs that are out there are not evidence-based. And I just want to, I don't think Jim Barron is here anymore. Are you, Jim? No. We went out to his University Village retirement community, and he said in relation to a class, he's there, about falls, Jim said, I hope I got this right, I'm sure it isn't doing any harm. I wrote this down, Jim. But I don't think it is making much of a difference. And we didn't evaluate that class, but that is often the case in relation to falls programs because they aren't oriented towards balance and strength. They are not progressive, means you only get one set of exercises. And there's no continuum of programs. If you graduate from one, you can go to the next. So we are working in a sort of clinical trial program to look at whether an intensive program using MDs, OTs for home assessments, and home remodelers versus less intensive programs that might use social workers or even people doing their own self-assessments. We're trying to study which programs are likely to be most effective. We also have built or helped facilitate coalitions across the state. Because this condition is so multifactorial, it takes a village, in Hillary Clinton's view, to make a change. So we have coalitions that include aging, public health, caregiving groups, home modification, building groups, housing, social services, and other groups like first responders and faith-based organizations. Other ways to get the message out, and you can see at the bottom we've been extremely active in bringing the message and services to older persons in the community. We have 11 coalitions around the state. The favorite one we like to visit is Napa Valley. I won't go into alcohol and falls, but also we've been active in trying to change legislation and policy. First, to get evidence-based programs accepted. Second, we had a summit of California stakeholders up in Sacramento and one in Long Beach. We got a bill passed, not we, but a whole group of people, organizations for Fall Prevention Awareness Week. We got the Department of Public Health to raise fall prevention to be one of its 3 highest priorities. It was buried very low before. There's been a federal act, Senior Safe from Falls Act of 2007 that got passed, but without money yet. But we're hoping that the health care reform bill, which does have some incentives for health promotion, will be able to address fall prevention, which is mentioned 3 times in the very long bill, but at least it's in there. Finally, to show you some impact we've had, this is what the infrastructure looked like before our fall center started. And you can see that even we weren't even working with UCLA or Cal State Fullerton or the state of California. We were all doing our separate things. This is sort of what it looks like now. And just quickly, We're all working together. There are other groups, the California Department of Aging, Aging Network, Partners in Care Foundation, but we have filled in a lot of these boxes with a bunch of models, including Matter of Balance, which is a near falls program. We've got these coalitions going. We've got priorities. We've got training programs. I mean, we're on the way, but it's really just a first step in the right, what we think is the right direction. 1 minute. Next steps, future directions. We would like to replicate if our own program turns out to be successful. And other interventions for diverse groups, because most of them are not translated into any other language, maybe Spanish, but not beyond that. And we think that the diversity of a place like Los Angeles, people are going to resonate differently to different messages and certainly different forms of exercise. So it's important to adapt them. We want to develop this continuum of fall prevention programs across the state. We want to be able to expand training. So we're working with the fire department to train their EMS people who pick up a lot of people after they've fallen about falls, and to do home assessments in the time that they're there. They're often there for 15 or 20 minutes, and to make referrals. Also direct care workers, who are those people in homes dealing directly with older people. We have a grant from the SCAN Foundation to train them, along with Brad Williams from the School of Pharmacy. The program's called Pills and Spills. I think we got the grant just for the name of the program. But we want to ensure that fall prevention actually is implemented correctly in preventive health program in the new health reform bill. And we would be really pleased to have more collaborators from USC. You can see where it's interdisciplinary, but a lot of the interdisciplinary work is from another school that has blue in there. And we would like more collaborators here. Thank you very much. And I know a lot of my students are here, so I wouldn't say class dismissed, but it's nice to have you here. Any questions? Questions? Maria, uh-oh.
Do you have a website?
Oh. I'm sorry I didn't mention that. Our website is the #1 website in fall prevention. It comes up www.stopfalls.org. And Maria and Trevor were instrumental in that, and 2 of our staff people, Emily Neighbors and Anna Nguyen, are here, and Greg is here somewhere. We are the headquarters for the Fall Center, and the website is one of our really most important contributions, as well as keeping the other universities and groups involved. Any other questions?
In a large institution like the University of Southern California, is there any data on where falls occur on campus?
Well, they probably do keep data because people get sued about falls. But one of the falls occurred right in front of our Gerontology Center, which for years we were saying you needed to have handrails there. And only after that fall and a lot of lobbying and help from our dean did they finally put a handrail in on those very wide stairs. But cities only keep data in a similar manner when people complain and say I fell somewhere and are likely to sue them. So we could start on our own campus. Very good suggestion.
Upon being exposed to the clinical environment, I've noticed that some older adults often wait too late, like they've fallen beforehand before they actually make a visit to the physician. Is there statistical evidence or data regarding why?
Well, people who fall once, they sort of assume that was just an accident. When people start to have multiple falls, that's where we get the most concerned. And we have been working, for example, with Dr. Barron's retirement community, where they've done a good collection of people who have fallen once and multiple fallers, and you can see patterns of people who are multiple fallers. That is an extremely high risk once you've fallen a couple times within a year to fall again. But we would like people to do things ahead of time. So physical activity that relates to balance, checking the environment around their home, having their medications checked. Those are things people should do anyway, which would help prevent falls in the future. It's a very good question.
Does the Fall Prevention Center do any collaborations or any research on the anticipation of falls, how to, let's say, the kinematics of falling and like safer ways of doing so if like something were to happen? Well,
you know, that's a very good question. There are ways to simulate falls. So there is a Philips electronic company, which is into the health business too, has like a dummy that sort of simulates a fall. It's very scary to see. We don't ask people to fall, but we do show people how to get up after a fall. IRB would have problems with us, although there is a physical therapy researcher here at the USC who puts people in harnesses and he's illustrating the difference of traction in the falls we saw where it isn't adequate, where people slip. So there are ways to do research about that are really important. And some of it is going on at USC. I think my time is up. Thank you very much.
All senior citizens should get Life Alert.
Well, John was troubled about the discussion of castration, and I'm worried about falling now, walking up through here, watching Carmen Electra. My name is Kate Wilbur, and I'm pleased to be here. And I'm going to talk, I do health services research, and so I'm going to talk about, in general, the health services research that we've been doing. And I have a number of collaborators that I want to acknowledge here. Briefly, the problems with the current healthcare system are that the system is an acute care system for people who, by and large, have chronic illnesses. And so this creates all kinds of problems with transitions across settings, fragmentation across the system, the whole issue of going in and out of long-term care services, and manpower issues. So I realize that it's kind of the end of the day, and in order to engage people, I wanted to give you this little quiz. And Jerry has said whoever gets 100 on this, he'll take to dinner. So if you want to, you can just follow along with me. If you want to see how you do, feel free to do that. But here are the questions. What % of Medicare is spent on chronic conditions? And I'm going to go over the answers, and that's basically going to be my presentation. What is the likelihood that a 65-year-old will spend some time in a nursing facility? And then some true or false questions. For those who enter a nursing facility, the majority leave within 3 months. Is that true or false? About 1 in 5 older adults discharged from the hospital is readmitted within 30 days. Currently, there's about 1 geriatrician for every 3,000 older Americans. And finally, wellness programs that are effective for younger adults are equally effective for people who are 65 years and older, who are living with disabilities or who have lifelong sedentary habits. So we'll start with the first question. What percentage of Medicare is spent on chronic conditions? Anybody want to just throw out a number?
70%.
70%. Anybody higher? Lower? 70%? 80. I hear 80. Do I hear? Okay. Sold. No. So according to Bob Kane, who's a physician health services researcher, it's not 97%. It's almost all of Medicare goes towards chronic conditions. But we have a healthcare system that focuses on acute conditions. Most older Americans, 90%, have at least one chronic condition. Margie talked about arthritis. 3/4 of older Americans have 2 or more. And if you look at where the spending is, the vast amount of spending, 3/4 of it, is spent on people who have 5 or more chronic conditions. And this is only going to increase. So what we have for people with multiple chronic conditions is a service delivery non-system that there's a nightmare to navigate for people to get through. The Institute of Medicine about a decade ago did a study looking at how to increase quality, and this was one of the big issues, is this is a nightmare to navigate. It's a nightmare to navigate because all the services are siloed into individual services. And so for an individual, you can go into one service, you get assessed, you get treated, but you don't get from that service to another service, and there's not much collaboration between the services. About a decade ago, we looked at communities to see how people flow between the silos. We did a network analysis. I forgot to mention this. There's a woman in a group in Michigan who talk about the problem also being constant reassessment, and she termed the condition death by assessment, because, you know, when you go to the physician and they ask a question, then you go to the next physician and they ask the same questions. And for people with multiple chronic conditions going through the services, this is a problem. So here's the network analysis that we did, and this is actually a simplified version. And I like to take this slide up to show the legislators in Sacramento and other places. This is a very complicated system. This is the nightmare to navigate with the services actually. Well, those services won't make sense to you, but those are the services in the silos. So for people to get from one service to the next is extremely complex. What we need to do is develop a more coherent system where information follows people, we can transfer the information, effective referrals occur, and I'm going to talk a little bit about our research with transitions. And then we align the incentives so that the money does follow the person through the service delivery system, and they don't have to get reassessed in terms of having, or as we see often, people qualify for nursing facilities and then they have to stay there because they're not able to get the same benefits when they go to home and community-based services. One of the things that we've been doing is looking at developing an integrated information system. California has a 5-year grant from the Centers for Medicare and Medicaid Services, and so working with that, the California Community Choices, we've been looking at creating a data warehouse in California. This is a little snippet of some work that we did, and I will tell you, if I were to show it to you, it's really eye-glazing, because what we did is we looked at a series of assessment instruments that are used across those silos, and we tried to determine what questions are asked in each one and how much commonality is there. And that's one part of the equation, but even when you find commonality, then providers don't want to change. They say, well, we asked the question this way, and we're not going to share our information. So that's been an ongoing issue. But we're hopeful that, and in fact, there is legislation now in California, and there's some good promising practices in other states about sharing this kind of information across different settings. We've also worked with some people at UCLA to look at large linked data sets where the data, Medicare and various Medicaid services and in-home supportive services are linked, so you can actually follow people through these services and look at outcomes. And one of the most recent efforts that we've done is to look at the relationship between process of care and functioning and survival. So if people get good quality of care, does that lead to good outcomes, looking at this macro level data? And in fact, it does. And it suggests that if we have this kind of information, then we can have a feedback loop back into the healthcare delivery system to actually help us improve the delivery of care. This study also found, though, that vulnerable elders who were in the data set, these were people who got both Medicare and Medicaid, so they had an extensive array of services available, got about half of the recommended care, and that there was a lot of quality variation depending on the condition that people had, and that, not surprisingly, preventive care was what was least often seen. Various diagnostic and treatment procedures were provided most frequently, and that's where the funding has been traditionally. But care for geriatric conditions, and this relates to what we just heard about from Jon, things like falls and incontinence receive poor quality indicators looking at this data set. So one of the issues is getting the information. in line and information to follow people. But currently, when it doesn't, how do you help people navigate the system? And one of the ways is through various care management approaches to try to help be sure that people get the kinds of services they need. And one of the issues that we looked at was people who are in multiple services who have multiple prescribing physicians and get multiple drugs and what goes on there, and found that in about a quarter of the cases in this dually eligible sample that we looked at had medication problems, polypharmacy, therapeutic duplication. And so with this intervention, case managers and consulting pharmacists went in and made recommendations to the physicians, and in fact, in the majority of cases, 61%, the problems were addressed. We also did a study, randomized controlled trial, looking at a very simple intervention, which was a monthly case management phone call intervention to help people make sure that they were getting the services they need. It reduced hospitalization, it was cost effective, and much to our surprise, it had a positive mortality effect. People in this intervention actually live longer than people in the controls. We think because it was a very empowering kind of intervention. Okay, so that was one. We don't have a chronic care delivery system, but 97% of costs are related to chronic care. What proportion of people 65 and older will spend some time in a nursing facility? I should have asked you what your answers were without putting it up here, but it's, depending on which study you read, 40 to 45%, and about half of women over the age of 65 will spend some time in a nursing facility. So at any given time, about 4%, 3 or 4% are in facilities, but over the lifetime risk is very high. True or false, the majority of those who enter a nursing facility leave within 3 months. It's true. The vast majority will leave within 90 days, and we've looked at some of these patterns of leaving. This is looking at everybody in a study that we did. We actually started the study to look at who didn't go into nursing facilities, and we found it was much more interesting to find out who went in and then left. And so what we see here is that 70% leave within 3 months. But I think what's even more interesting is this next slide, which is among those people that leave and go home, 91% leave within 91 days. So there's a pattern, a lot of people going in, often for rehab, for short stays, back to the community in less than 90 days. And who are the people that leave? By far the strongest predictor was having a supportive person at home who was supportive of the person being discharged. The characteristic that suggested the person was least likely to leave was to bounce back into the acute care facility, which gets to the next question. Which is about 1 in 5 people are transition within 30 days. My presentation's over there. I didn't bring it up. And that is absolutely true. And I think if you look at within 90 days, 1 out of 3 people who exit the hospital transition back within 90 days. So these patterns of care are that people are bouncing back into the hospital. The people that end up staying in the nursing home are people that bounce back. They're not stable in their care setting. This is a very interesting exercise. I'm trying to remember. What was the next question? Oh, now we have to go through the whole thing. All right. And if I were to talk really, really fast, this is what my presentation would have looked like. Okay, thank you. And no more remote. No more remote. Okay. All right, so we talked about that. And I already talked about that. Manpower issues. One of the biggest issues is that we don't have the workforce necessary to address an aging society. So the question was about there's 1 geriatrician for every 3,000 older people. That's false. In California, it's 1 per 4,000. Nationwide, it's 1 per more than 5,000. Institute of Medicine study a couple years ago said that our workforce is woefully unprepared to address the aging population, and not only on the physician level, but also certified nursing assistants, geriatric case managers, geriatric nurses, social workers across the whole range of services. Finally, wellness programs. This was a very neat little study that, again, used a comparison group, took pretty much lifelong couch potatoes who had no interest in exercising, and asked them if they wanted to participate in an exercise program that included, the front end of it was behavior change, and so it was really motivating to exercise. And then when they had gotten into what motivates them, why would they want to exercise, then they actually engaged in an exercise program. And the results were really dramatic. Across the board, improvements in strength, flexibility, and balance on all the measures, significant. And then what we did is we took the comparison group and put them through the program, and they had stayed stable when they weren't getting an intervention, and then they showed all these same kinds of outcomes. The other nice thing about this study was that it was a multi-ethnic study, so across the various subgroups we saw the same kind of program. So I think there's a great take-home that it's never too late to exercise, and that if people can find the right kind of motivation, and then over time the exercise became its own motivator. No, okay. So where are we in terms of health reforms? We talked a little bit about this today, but I think the exciting thing that's in the health reform bill as kind of a first step is that there are actually efforts to move the healthcare system towards more chronic care delivery. So there are incentives in the healthcare bill for primary care doctors. There are incentives to improve coordination, to begin to move past the silos, to focus more on preventative care, and then, of course, which you've all heard, to address the infamous donut hole that's part of Medicare Part D. So I think as we move forward with health services research over the coming years, I think we will see more movement towards a chronic care delivery, but there's a lot of hurdles and a lot of challenges that await us. Thank you. Does anyone have any questions?
Thank you very much for that very nice presentation. Do you see the application of the medical home model as one way to implement some of these changes that we may want in order to address these both primary and chronic care problems that we're facing now?
Yes, and do you want to say anything about the medical home model in terms of what it is, or would you like me to? No, okay. One of the issues is that people don't have a primary care home, so they get referred all over to various specialists. So this model would provide a primary care and provide a team, and I think we're seeing more of this as a way to provide, to address the issues of people who have chronic conditions in a more systematic, coordinated way. So I think that it's very promising, but I don't know that there's been, that the evidence is completely there that this will do the trick.
Your reference to that paper by Gretchen Alkema brings to mind a study that had been unpublished for a while out of UCLA on studying treatment of suicide prevention, and found, was a remarkable finding. It found that a significant beneficial effect from sending out a postcard to the group of people who had tried to kill themselves and didn't, and saying basically, how are you doing? We've thought of you, or something about that. Something, just that, seemed to have a beneficial effect. So I mean, when I first read about that, I mean, I didn't believe it, but it turns out to have been a finding. And I don't know if you've ever heard of that, but when you mentioned Gretchen's paper, that came to mind.
And you're talking about the one with the mortality effect, that people in the treatment group actually live longer. We didn't believe it either. We thought, well, this little intervention can't really do that. But I think what it gave people is control rather than the traditional approach, which is here's the services that you need in order to stay in the community. And so they had a great deal of control and a great deal of variation in the services they got. And so Gretchen presented it, and several health services researchers said, you can't really measure this because there's no systematic intervention, which is true, but we thought the intervention is no systematic intervention. It's whatever the person really wants to ask for is what they could get help with. Okay. Thank you.
Well, thank you very much. It's just a pleasure to be here, and I want to thank Jerry and Randy Hall's office for inviting me. And when I looked to see that I was toward the very end of the program, I decided I was going to need to keep people awake. And so that was part of why I asked this question, what do springs, serious games, and microstimulators have in common? It sort of forces us to think about this. And the answer to that question is they all come together in the Rehabilitation Engineering Research Center on aging with a disability. And that's what I'd like to talk to you about. This is a NIDER-funded Department of Education center that we are in our, we've gone through about a year and a half. We're in our second year. And I want to tell you about the progress. I want to tell you about the programs that we have going on and the people that are involved. And I think I forgot already because I have memory problems. So the name of the center is Optimizing Participation Through Technology. It's called OPT, RERC. This is our organizational structure. We have a wonderful leadership team at the top with the umbrella. We have 4 project areas that are focused on harnessing technology to slow the aging with a disability problem. So you think you have problems when you're just aging, add a disability onto it, and it accelerates the aging process. So we're trying to understand that, and we're trying to harness technologies to reverse or at least stabilize the disability. The 4 projects are dexterous manipulation with the fingertips, virtual reality and gaming for home-based motor assessment and training, optimizing mobility in the home and community for manual wheelchair users, and neuromuscular electrical stimulation for mobility. And I'm going to tell you how that fits together with the springs, the serious games, and the microstimulators. These projects have a number of research and development activities. And we have been in the first year and a half working primarily on the development side of things. We've been doing some of the research, and I'm going to share that with you. And our target beneficiaries are people who are aging into disability, as well as people who are aging with disability. And you can see it's a pretty diverse group of patients. We have a number of industrial partners, some of which we're starting to work with, and we have an advisory board that is giving us lots of good advice. I want to tell you how fortunate we are. We have a multidisciplinary leadership team. And I use the word multidisciplinary up here because all of these folks come from different disciplines. And what we've spent the first year and a half doing is learning each other's language so that we can carry out interdisciplinary research. So when the physical therapist talks to the engineer, they talk in different languages, and we're starting to now communicate in the same language. When the gaming computer science student is building games for people who are going to use them to control their balance, they need to understand what are the important issues that the individual faces and how can that get translated into an effective and engaging game. So Phil Riccio is the co-director. Phil's actually in the back of the room. He's has a joint appointment in biomedical engineering here, and he's the director of the Rehab Engineering Center at Rancho Los Amigos Rehabilitation Hospital. Florence Clark is the director of our clinical translation focus. She is in the Division of Occupational Science and OT. Eileen Crimmins, who you all know, is the director of Gerontology and Policy, and she keeps us on our toes and also keeps us focused on the aging question. Carl Kesselman and Richard Nelson are responsible for dissemination and also the IT, the technical assistance side of things, and have helped us develop our website. Gigi Ragusa is the Director of Assessment and Evaluation. She's from the Rosier School of Education in Viterbi and Engineering. Joe Kepnick, who is no longer here, was the Director of our Technology Transfer. We haven't yet moved into Technology Transfer, but that's something we will be doing in probably years 3 and 4. Francisco Valero Cuevas is the Director of Training and Education. He has a joint appointment in engineering and biokinesiology. And then Steve Sen is our Director of Data Management. So you can see we have an excellent group, and there's no reason why we can't be productive. The project leads are here at USC in Rancho. Francisco's spearheading the dexterous manipulation project. Skip Rizzo and his team, Cheryl Flynn is actually here and did a lot of the demonstrations during the lunch hour, are leading the virtual reality and gaming for clinic and home-based motor assessment. Phil Riccio is leading the project on optimizing mobility in the home and community for wheelchair users. And Lucinda Baker is leading the neuromuscular electrical stimulation for mobility piece. Part of our model that we work on is this common language that has been proposed by the World Health Organization. This is the International Classification of Functioning, Disability, and Health. And there have been some interesting discussions. One written by Alan Jetty, Toward a Common Language of Disablement, published in the Journal of Gerontology the end of last year, and a commentary by Vicki Friedman talking about adopting the ICF language for studying late life disability, a field of dreams, pointing out that this is a language model but doesn't really get at the dynamics. And then there was a very nice paper by Goralnik talking about the challenge of understanding the disablement process in older persons. Where we function in the center is really attacking body function, body structure, in order to enable activities that then allow participation. So we make some assumptions. We measure the effects of what we do at the participation level. But part of the research that we're doing is to understand the dynamics, the relationship between what a change here can do and what effect that actually has on activity, and then what effect that has, whether or not it has an effect on participation. So we're much more interested in the dynamics, and so this model, which is the top-down model, is much more descriptive of the kind of research we do and the sorts of questions we ask and what we're interested in. So we start out with somebody who is disabled, and we want to understand, we want to elicit effects that are recovery or at least prevent further disablement. So we work pretty much at the resource level with the physical and cognitive mechanisms, including musculoskeletal linkages and the control of body movement types and the ability to plan actions. We work at this level with our interventions in order to, we start with them with asking our patients what roles can you not do that you want to be able to do, and how can we harness technologies to get you back to this position. And obviously, it involves certain skills. the ability to achieve meaningful goals with consistency, flexibility, and efficiency. So our criteria for whether or not we've had an effect is governed to some extent by what this model says in terms of the actual dynamics of the process. And it's not always straightforward. So that's really the challenge. So let me tell you about the projects. The first one has to do with manual dexterity. Turns out that manual dexterity is a pivotal skill necessary for independent function. There were some studies done in the 80s showing that losing the ability to simply open up a medication bottle or a jar or even open up food is directly related to people losing independence to take care of themselves and ending up actually going into a care facility where someone else has to do those things with them. And this capability declines with age, and in the case of many catastrophic incidents like stroke, and also in progressive disabilities such as osteoarthritis and cerebral palsy. However, we need better assessment tools and targeted interventions to slow down this or reverse the disablement process. And Francisco and his team, and I'm going to figure out how to use the mouse here. I'm going to show you. This is they've developed this, it looks simple. These are springs that have to be compressed. There's a significant amount of control that has to occur in order to compress these springs and keep them from buckling. And you can change so this is basically a strength dexterity tool. You can see that pops, so even where you grab it, and then the process of compressing these springs, you can change the difficulty of the task by changing the thickness of the spring. Now here's an individual who's practicing with this, and she has had a stroke. So even notice that where she's holding this, and notice that she could not maintain it at all. So the evolution of the strength dexterity system, Francisco and his group have really developed this, and they're really studying the dynamics of this control, which turns out to be very, very important for manual dexterity skills. We do a lot more manual dexterity skills with all of the instruments that we now have, our iPhones, and we use our fingers a lot for manipulating the environment. The typical clinical measurement for these kinds of things is usually grip strength or pinch strength, and this does not get at the control requirements at all. So we think we're onto something that's going to be quite useful for measuring dexterity across the board. The second project, pain-free shoulder motion, this is critical for wheelchair mobility. Painful shoulders are a common progressive disability in chronic manual wheelchair users. And this is an example of one of the strength exercises, very specific muscle strength exercises, Phil's in the background here. And our previous research has basically shown that a 12-week home-based program of muscle-specific exercises and optimal movement strategies can significantly reduce shoulder pain and increase participation in meaningful activities in chronic spinal cord injury patients. And this is an exercise group compared to a control, and you can see this is the WSPI, the Wheelchair Users Pain Index. We had a significant decrease in pain in the exercise group. So we're currently doing some research on the biomechanical stresses of, just look at the stresses on the shoulder complex for this gentleman who is just transferring into the car. This is a regular activity that he does daily, and what he has to do. And of course, the shoulders were not built to take these kinds of stresses. If he loses this capability, he loses a tremendous amount of independence. And the last project is the pressure ulcer prevention, and I don't have to tell you how much it costs to heal a pressure sore, but it is critical for those who have disability-induced immobility. So simply sitting and not relieving your weight because you're insensate leads to pressure sores. It turns out that stimulation with very small implanted neuromuscular electrical stimulators that are about the size of a large grain of rice has the potential to counteract the major etiological factors in pressure ulcer development, including the immobility. We can stimulate and actually get muscles to contract and actually shift your weight. It deals with soft tissue atrophy, and it also deals with hypoxia. So this is the third project, and believe it or not, I am going to be done in a minute. The neuromuscular stimulation project is a preclinical project, and it has a very small clinical trial attached to it. To develop we're working very closely with industry, a stimulated active seating for pressure ulcer prevention called Sassy Pup. It's quite sassy. So the virtual reality side of it, and I had a slide before this one, is, whoa, previous. Oh, that's not the one. Okay, there was a slide between this one and, you didn't take them out. Okay, I had a slide where we are actually, the VR group, there it is. I knew there was a slide there. I'm not imagining this. So our serious game group are developing games that are aligned with each of the projects. This is just an example for the manual dexterity training, and you told me it was going to work. I did. Worked this morning. All right, so we don't get to see that one. This is the one of the shoulder ones. This is driving through a canyon simply by moving this. There are two cameras. And simply by moving this, we could attach this actually to a pulley, and you could actually be driving this while you're doing your exercises. And the accuracy of following a trajectory for your exercises would I've got one more slide. Interesting. Remember there was another one.
Go back.
Oh, it's in that order. Let me play you this.
Okay.
The question was, what is the most disabling thing about aging?
So many treatments, and then if I'm not making the progress that they want to see, they will stop it. So that kind of frightens me. Secondly, if the muscle in my legs don't get any better, and I kind of go backwards and get worse, if I end up in a wheelchair, I'll have to move because I live in a 2-story house. That bothers me.
I have apraxia and aphasia, so everything is more difficult because I have those problems.
The part of being dependent on others when it comes to doing things, because I'm so independent right now, and losing the strength of my arms, that concerns me.
Well, because you can't walk, that really kills me, because you can't go anywhere.
That doesn't trouble me. When I have a birthday, when our family has a birthday, we celebrate. We don't count. So that's all set aside. And regards to disability, roll up your sleeves and fight.
More help with just everyday living, you know, depending on people. You know, like right now I can do a lot of, I drive, so I'm going to need a driver probably later on. Pretty much not being able to do more for myself.
I can't really say that I have too many things that bother me about being older and injured. I think being older and being injured actually helped deal with the problem. I mean, you got a little more life experience, got stuff to deal with. It's a little easier. I don't really find anything that I can say really concerns me more now than it did before when I was able-bodied and older.
So you see there's a very diverse set of responses to the question with regard to aging. What are the things that trouble you the most? So my last slide is our website. You can visit us. I think there are lots of kinds of collaborations. I think we would like to work with Jon and his group. And we're just getting started, so please contact us. If you just www.edu aging RERC. Thank you very much. Any questions? No, yes? John.
So some of the people you showed, like the man getting in the car, he seemed to be younger, and I don't know that a lot of older people would be able to even attempt that.
Right. So the issue with shoulder degradation in spinal cord injury is that the issue is they're aging with this spinal cord injury, and most spinal cord injuries occur when you're very young. We don't start seeing the breakdown of the shoulder complex until they've actually been a manual wheelchair user for about 20 years. So these people are, in their 50s and 60s, and that's when it starts happening.
Do you see any relationship between physical improvement and their psychological, well-being or satisfactions?
Yeah, so we have actually used a number of instruments like the SF-36, and we do see changes when they improve in their physical capabilities, and they realize that they have control over something that they can do on a regular basis to improve or reduce their pain. We see a direct increase in their psychological well-being, and I think that's known in the literature, so we're not surprised about that. And I think part of it is knowing that they can take control and there is something they can do about this that's really important.
For people, those interventions doesn't work for them?
The issue more is probably compliance. The issue is whether or not they want to participate in something like that, and so that's where the VR gaming work I think is really has a lot of potential because it's engaging, it's fun. What we have to be careful of is that people are doing these movements correctly. They're not just flailing around, and because there have actually been an increase in repetitive stress injuries from playing with these games. Great, thank you.
I have to say there's enormous pressures being the last presenter at the end of a very intense day in rainy downtown LA. So for those of you who elected to stay, I appreciate it. I understand the sacrifice. And Whitney's already telling me there's only 10 minutes. I'm going to be fast, so it's going to be good. Unfortunately, I have to tell you I don't have any cute or fun clips, but I'll try to be as charming as I possibly can, which is really pushing it. First of all, I'd like to acknowledge my partners on this project, Partners in Care Foundation, and our funder, which is United Pacific Care Foundation. So what is health literacy? So there's a lot of different definitions to health literacy, and what we're really going to talk about today, briefly, is individuals' capacity to actually obtain, process, and understand basic health information that's needed to make appropriate healthcare decisions and to access care. So it's multidimensional. It's not just knowing the information, but it's being able to do something with the information. Particular groups that are at risk for health literacy barriers are older adults, minorities, people with low socioeconomic status, and the medically underserved. So, I was looking at the agenda and I was thinking, I'm last. Wow, I'm last. And I was thinking, well, maybe it's because I'm the only assistant professor. Okay, that's, I don't have tenure. That's the first thing you think about. You think about tenure all the time. But then I thought maybe it's because I'm shortest. But then I realized it just makes sense because I'm talking about end of life. And it just makes sense to end the day with end of life. Well, that's how I rationalized it. But so what I'm really going to talk about is the use of a novel approach to improve health literacy around hospice care for African Americans. There's a lot of literature. In fact, I did my dissertation in this area, and this is really where I started thinking about this, is looking at the disparities in access to hospice care and other end-of-life care programs. And there's a ton of literature out there that shows over and over again that African Americans are less likely to enroll in hospice care, which seems really strange because hospice is generally provided in the home, and African Americans are more likely to die in the home than other populations. So it kind of made me think about why do we have this disconnect. So when I went to literature, there's a lot of barriers, and I'm just highlighting a few here. Is some of the things that really stood out was the fact that they had no personal experience of hospice. And that there's a lack of knowledge about hospice. So they don't even know that there is a hospice in some case, or they have a misconception about what hospice is. And generally these misconceptions around hospice are about the location of care. So a lot of people think that hospice means you're going to be institutionalized. So if you go to hospice, you're going out of your home. Another misconception is that when you go to hospice, that means your doctor's giving up on you and that you're going to die. So there's a ton of literature as well that shows that African Americans are less likely to be referred to hospice care compared to whites. So we have a lot of different issues on both the provider side and the patient side, and systemic issues as well in terms of the hospice benefit. In fact, there was a recent study, I just want to highlight a recent study that just came out. So even though some of these references may have started 2003, 1999, but still in 2009, we have a couple of other studies that show that we still have these problems. A recent CanCourse cancer, a national cancer study looking at lung cancer patients in stage 4 lung cancer patients in the last 6 months of life showed that less than half of these patients had hospice conversations with their physicians. So physicians aren't having these conversations with their patients, even now, even today, even after we've made a lot of effort and stride in getting people to the appropriate care. If you're African American, you're even less likely to have these conversations. So what are role model stories? Role model stories are true stories of people in the community, and they use their actual language. They bring in the context. There's some background information so that people can identify with the role model. And the purpose of these stories was to increase knowledge and to impact attitudes, correct misconceptions, and to generate a familiarity with the hospice service. And this approach is grounded in theory. So one of the theories is the theory of reason action. And basically, theory of reason action says that people's behavioral intentions are based on their perceived social norms. So what they think other people like them are doing. And that plus their attitude, whether they are positively inclined towards this behavior or towards this action, or negative. So these two things combined lead to your behavioral intentions, and your behavioral intentions are closely linked to your actual behavior, whether or not you're going to do this. And this paired with social learning theory, basically that people can learn vicariously through watching or reading, as you'll see, you actually have these brochures in your packets, reading stories of people they can relate to and identify that they can learn and benefit from that. This approach has been used with health promotion generally around prevention activities with HIV prevention and smoking cessation. And it's been found to be effective in those environments, but it really hasn't translated out of that into areas of research or practice looking at trying to reduce healthcare disparities, particularly in terms of access to care. So how did we do this? How do we put this together? Recruitment, we recruited, this was probably the biggest challenge of the project, is trying to find African Americans in hospice to actually recruit, because there weren't a lot out there in the service. So we distributed flyers to hospices who took them to their African American clients, and they would call me, and I would tell them about the project we were doing and recruit them to participate. And then we would have an interviewer that would go out to their home and interview them or their family members, sometimes both, using a very structured protocol that was developed specifically to elicit some of these theoretical concepts. So some of the things we wanted to find out is, what were their misconceptions about hospice? How did they overcome these misconceptions? And we had kind of made we kind of were resolved to produce and record whatever their true outcomes and impact of that service was, whether they were positive or negative. Our goal wasn't to get people into hospice. Our goal was to get them to make an informed decision. So what we did is we tape recorded these interviews, and we transcribed them verbatim and developed the stories, and then we sent the materials out, or draft materials out, to 3 different printers and graphic artists, and they developed mock-ups of these brochures. We took these to the community. We went and held three or four focus groups with older African Americans, and we asked, what do you like, what do you dislike? And they were really willing to tell us, especially what they didn't like. I mean, down to the nitty-gritty, that there was a picture of a family of standing around a woman with a wheelchair, and they absolutely hated it. Said they felt like she was being coerced, and they were feeling that they were threatening her and everything. So we changed our art and the font and the title and the size based on everything they said in the focus groups. So this was really developed based on the feedback we got from the community. So we developed the materials, and right before we went out for the final printing, we took them out to some geriatricians and case managers, and we did a final testing, and they did some nitpicking, some things that Jon would appreciate, increasing the font, and he knows these populations, and things like color contrast, making sure the contrast was good. So we did our final testing there, and then we ended up with our final product. The story development, again, we maintain even grammatical errors. We wanted to retain the richness of the language, the cultural context in which these people were telling their story. And then also literacy level was important. We wanted to maintain a low literacy level, so we tried to keep it low, around 4th grade level, and reduced these long interviews into stories of 200 to 500 words. This is the brochure. It's in your packet, so I hope you'll read that in your free time. This is just an excerpt of the story, but you can see that it really brings in the personal context. I was born in El Paso, Texas in 1927, retired from the city after 25 years. My health was very, very good, but my doctor told me I had emphysema and, well, my lungs were in bad shape. I was very sick, so I figured I'd try anything, Turns out that hospice is very good. I thought being in hospice meant I'd be dead soon, but as far as I'm concerned, hospice has prolonged my life. So what we did was incorporate his potential barrier into the story, and then talk about how that was overcome, and his reward that he received at the end, so his outcome. So after it was produced, we pilot tested it. It's a little backwards, but we were working against the clock here. And we had a pre-post study. We recruited 71 African Americans from community service organizations that were 62 years of age with 2 or more chronic conditions. And we did a pre-post survey on their attitudes, knowledge, and intentions to enroll either themselves or a family member into hospice. These are the demographics. And you can see that African American, one person reported that they were biracial, so we didn't quite have 100%, but it was pretty much 80% female, diverse in terms of education and marital status. So what did we find out? We had an increase in knowledge from pre to post, and we particularly, I just want to note that we particularly did not let them talk to each other about these brochures, because we really wanted to test the brochure as a standalone, not as something that they would talk about with their family. So they kind of went off to a cave, read this, and came back out and were surveyed again. Their attitudes towards hospice significantly improved after reading the brochure. And this to me was the most important because of the link between intentions and behaviors. This was the most important. And I was running the data and I was thinking, okay, just hold your breath, just hold your breath. And it was really exciting to see that at baseline, 84% either agreed or strongly agreed that they would consider hospice for a family member if they were seriously ill. And that increased to 93% following the review of the brochure. And similarly, for themselves, it went from 83% to 96%. So it was exciting. I mean, we still have work to do. This is just looking at intentions, not necessarily clinical outcomes. But we think that we could potentially have a greater impact within a clinical or group setting, so that where there is conversation, people can discuss this. So anyway, we have more research that we want to do in that area, and then also looking at extending this beyond a hospice conversation and into end-of-life decision-making. So encouraging people to talk to their physician about what they want at end of life, their advance directives, talking to their family. So I promised you I would be fast, and I was, right? Any questions? John?
Do you think it would be different if you had short film vignettes versus reading?
We actually want to do that next. We want to bring in the film as well. So, and I don't know the answer to that. Any other questions?
How is the population in general influenced by their physicians? Because I could think about the physicians, they could have a big influence, right? Because they talk with them a lot and discuss this maybe.
Yeah, and looking back at the theories that we used to guide this, theory of reasoned action really say that for particular behaviors that certain people are going to have more influence than others with that behavior. But some of the literature actually shows that there's a little bit of a distrust with African Americans and their physicians, particularly around the conversations of giving up aggressive care. So it was. I think that's part of why we went to more of the social norms rather than the physician-generated kind of discussions. Good question. Any other questions? Okay, thank you.
Well, you hardy souls who are still here, we're going to reward you with cookies and other very healthful things outside. These are special kinds of cookies that will extend your lifespan, reduce your lipids, and make you taller. I'd like to thank you all for being here, for interacting, being such a great audience. I want to thank the panelists, many of whom could not stay. I think they did a splendid job. And I know they did a splendid job. We've been chatting a lot during the breaks and lunch and whatever. This is, we know where you live. We have your email address. We know where you live in cyberspace. This is not the last you've heard from us, and we hope that you will maintain contact with us in one way or another. We hope that there have been some seeds sown for collaboration. We certainly know that people have, just from comments, people's minds have been stimulated and thought-provoking ideas about what you might be involved with that might relate to the important issues with regard to gerontology. I think one thing we've sort of when you're in this school, you know that this is really interesting and challenging stuff and very important. And maybe for some of you, you weren't quite as aware of that as you are now. And I hope that that is something that the takeaway would be positive for you. There are evaluations in the bags that you have. I hope you take due notice of how handsome those bags are. We hope you will carry them around and flash them whenever you have a chance at football games, sporting events, students during lectures, whatever. Hold up the bag. There's a ditty. I've been debating with myself whether to mention this. Those of you old enough to remember Tom Lehrer, who remembers Tom Lehrer? One of my, I'm not sure I can say this with a straight face, but it was a song that a little ditty that he put together that seems somehow relevant to a lifespan symposium like this, and it's sort of like, as you go sliding down the razor blade of life. So it's not quite so grim as that. Well, I can see that went over well. But it was very enjoyable and fun to me when I was in college when I heard that. But there are serious issues about how we all cope with and deal with the challenges and stressors in life, but also how we take advantage of the benefits as we get older, and of the challenges that get us to think about the meaning of things. And I think behind a lot of what was said by the various panelists is that not only is life not over at 65, but there's a lot ahead that's a lot of interesting fun and enjoyment and potential. And the people who are in this room are studying those things. And I admire you all, especially the students who've gotten into this field at an early age. So thank you all very much for coming, and do have snacks outside.
Yeah. I didn't get your camera thing then. Because they had to cut the brake.
They cut the brake on me.
Why?
Turn the mics on.
17.
Oh, no. You're good.